Pensacola, Florida, where they got 8 inches of snow.
And we're live.
All right. So good morning. It's Wednesday, January 22nd. This is Senate Health and Welfare. We have a lot of good work today. We're hearing from Green Mountain Care Board to start us off, and just a little bit about who they are and what they do. And then after that, we'll be looking at EMS in the Blueprint for Health and hearing from some of our healthcare folks.
Madam Chair, would you mind if we push that blue button?
Oh, sure. Do you mind pushing that blue button?
And I will
Oh my God.
apologize.
Thank
It is a
you.
touch screen.
That's terrific.
I will apologize in advance. I have to leave just before 10 for the e-board meeting at the governor's.
Well, that's important. So, and please do.
So we know how much money.
Yes. So thank you for being here. We have the chair and a member of the board with us. We've asked you to give us an introduction to what the board does and a little bit about some of the board's work. So, well, why don't you introduce yourselves for the record and then we'll hand it over.
Jessica Holmes, I'm one of the board members.
And I'm Owen Foster, and I'm the chair.
And we have your slides up.
In advance. Our intent today, first, thank you, Chair Lyons, for inviting us into the committee, for hosting us today and hearing from us. We think that healthcare is at a tipping point in Vermont and a problem that needs to be addressed with alacrity. And I'll go through some of the data. Senator Lyons' word.
It's our favorite.
It's a good one.
So I'm going to give an overview of who we are, just to level set for the new members and for the committee, to who we are and what we do. I'm going to give some data and information about what our healthcare system currently looks like and some of the challenges we have. And then Member Holmes will provide an update on the Act 167 transformation, and then we'll close out. And of course, if the chair pleases, we can take questions at any time, if that's what the committee would like. So go ahead, Kristen. Just to remind everyone who we are, the Care Board was established in 2011, and we have 5 board members with staggered 6-year terms, and we're an independent organization and quasi-judicial. I'll go through what those mean really briefly. So there's a chair, that's me, and then there's 4 other board members. We have different backgrounds and different disciplines that come together in evaluating really hospital budget requests, accountable care organizations, and then a segment of the insurance budget. Quasi-judicial, what that means is that we act as sort of like a judge-like function. A party comes before us and says, here's what we would like. We'd like to raise insurance rates this much money. We'd like this much more money in hospital revenue, whatever it may be. We take evidence, we review the evidence, our staff does presentations, and then the board members deliberate in public, live, with public available to comment and submit comment before the deliberations and actually during the deliberations before we actually end up voting. So I think that's a really good structure in that we're apolitical. There's no political, well, I shouldn't say no, because there's always some political environment going on, but we're not a political branch, and we don't answer to the governor, and we don't answer, we're not responsive. We don't work for the governor or a particular branch of government. And that's how it was set up. So we'd be independent. We wouldn't have one person making a decision. It takes 3 votes to get anything done at the Care Board. 3 votes, which are sometimes harder to get than you think.
Oh, we have it. We have to see.
Yeah. You get it. The staggered 6-year terms was intended so that not one governor would appoint all 5 board members. Governor Scott has had a lot of electoral success, and at this point, he has appointed all 5 board members. Just real briefly, I'll give you sort of the scope of who we are as individuals and our backgrounds. Tom Walsh is a health policy expert and teaches at Dartmouth. Dartmouth has a well-known and highly regarded health policy school where Dr. Walsh teaches. He's also a physical therapist by training. He's been on the board about 3 years. Dave Merman is a doctor. He's an emergency room doctor at CVMC. And before that, he was an emergency room doctor at UVM Medical Center. And his wife is also a doctor at the UVM Medical Center. He joined the same day I did, a fateful day in October 1st, 2022. So he and I have been here about 2.5 years, or coming about 2.5. Member Lunge has been here, I believe, about 8 years now. She was the director of healthcare reform for Governor Shumlin. and has been instrumental in a lot of the state's healthcare policy efforts over the years. Her term, she was reappointed for a third term recently, maybe a year and a half ago or so, and she will be leaving the board on April 5th of this year. So there's a nomination process going on. And how we're appointed, it goes through a nominating committee, which has some legislative representatives, I think business community representatives. Are you on it?
I don't know if I'm gonna be reappointed, but I have been on it. Yeah.
And once the nominating committee takes applications, they review them, they interview the candidates, and then they select a list of people to pass up to the governor as suitable candidates for the positions of board member. And then the governor chooses from that curated potential list of people. And then they're appointed and confirmed by the Senate. The Senate chooses to confirm them. And then Member Holmes, I'll let you introduce yourself.
So again, my name is Jessica Holmes. I actually am an economist by training, and I teach and have taught at Millbury College since literally September 11, 2001 was my first day of teaching there. And I've been on the board now. I'm in my second term, so I am in my 10th year.
Member Holmes also teaches health policy at Millbury College and just started a health policy program at Millbury. So I think it's a good array of skill set, in that you have health policy people, you have a physician, you have a health economist with a PhD, and then I'm the chair, but my job in the past was I was a lawyer at a large law firm in Boston from Middlebury, Vermont. And then right before this, I was a federal prosecutor with the Department of Justice here in Vermont. I defended doctors in medical malpractice cases for FQHCs. And then I did large healthcare fraud cases against pharmaceutical companies, electronic medical equipment companies. I was involved and led one of the charges on Purdue Pharma, one of the criminal charges, which took a number of years. Both led the larger resolution. Thank you. Go to the next slide, Kristen. It's important to remember what the Care Board does and doesn't do. Sometimes I think people have a perception that we do a lot more than we do. We don't regulate the entire healthcare market, and we do not have authority over policy in all segments of healthcare. I think sometimes we get more focused because of our hearings are all in public, and the public can come and the media can come and they see us deliberate in public. But that does tend to lead to a perception that we do more than we do. And we have probably less control than I think is widely understood. So what we actually do is a small bucket here, this green one, and we regulate health insurance requests, but only a small segment of it. So the healthcare market in Vermont has QHPs, qualified health plans. That's about 65,000 lives or so. Then it has self-insured. Then there's the state plans and the union plans. And we only do that QHP plan, only about 65,000 lives. And in connection with that, really all we do is look at how much rate increase are they requesting to charge their customers. And we'll talk about how large those have been lately. And we'll talk about why they've been so large and why it's such a problem. Certificate of need, that's a process where providers can come in and say, we want to build a new thing. We want to build a new surgical center. We want to redo our emergency room department. And that's a process where they submit applications, we review them, and then we make decisions. I've heard that there's potential discussion this year about certificate of need laws and like what the right thresholds are. And I'll just comment that generally speaking, the Care Board and I have been supportive of reviewing those, because the certificate of need is actually a barrier to competition and a barrier to market entrance. And why that is because it's expensive to go through the process. It's time consuming, and not everyone can deal with that. So there is opportunity to look at that law and see if there's a better way to do it so the thresholds are higher so more competition can come in. Competition can be very good for healthcare markets. It's also hard to manufacture. It's difficult to crack healthcare markets. And then hospital budgets is sort of the big one that we do. I'm going to be approximate in some of the numbers today, but I think it's about $3.5-ish billion currently in hospital budget requests that come in every year. There's a significant amount of money. State's healthcare systems over $6 billion. Hospitals are approaching 45-ish%, give or take a little bit, of that statewide healthcare spend. And what we do there is we decide how much additional revenue they can charge and how much more rate they can charge. Rate being how much more the insurance providers will pay. And it's important to remember that when we increase the rate for a hospital, how much they can charge insurers, we're effectively saying how much more the insurance companies have to charge their customers, because the customers are the one that pay the insurers. I think in the past, there's been some confusion as to like, well, get more money from the insurance companies. They have money. And we'll talk about that a little bit today. Vermont's insurance market's a little bit unique in that we don't have a significant entry from the large national providers like United, like Cigna, like Aetna, who are for-profit with shareholders who tend to do quite well on those investments. We have a couple local insurers who are the dominant players in our market, and their financial position is very, very different from United Healthcare's. That's important to recognize. I think Blue Cross is about 66% of our commercial insurance market. What we don't regulate are federally qualified healthcare centers, which are a lot of our primary care providers. Independent providers, we don't regulate. Ambulatory surgical centers, once they get a CON, we don't have any say over what they do or what they charge. Out-of-state providers, we don't regulate certain payers like Medicare, the federal program for people over 65 years old, Medicaid, which is state and federal partnership. We don't regulate that. I can't tell you how many meetings I go to and people tell me raise the Medicaid reimbursements. We have no input over the Medicaid reimbursements, and we cannot influence really what Medicare pays either, unfortunately. And then self-insured plans. So they're plans for businesses that have a big enough pool and enough resources to be what's called self-insured. Which means they just essentially are paying for their own risk pool as opposed to in a broader, bigger collective of people.
You want questions while you're going along?
Happy to.
Okay, just.
Could you explain a little bit again about the setting rates for hospitals?
Yeah, the way we've done it for, I think really since we started, was looking at what their current budgets are, and then they submit an application with a request. And the request is really two elements. We put out guidance in March, and the guidance will say, here's where we would like the hospitals to come in this year. This is the expectation for how much more money you should ask for. And when we then do the budget, it's July, August, September, we can decide to go above that, or we can decide to go below that. When we make those determinations, when we set the guidance, it's generally around medical inflation or some inflationary index. The goal is we don't want healthcare costs to go like this, as state wages go like this, because it's just eating into more and more people's finances, taking money out of schools, taking money out of businesses, whatever it is. And so you want to keep it around what we can afford, and that's in the statute, that we want to have healthcare costs increase at a rate that we can afford. So we set the guidance, then the budgets come in July 1st. We have hearings and we review a large set of data comparing hospitals of similar peers to other hospitals nationally or regionally to see how they look. So some of the things we look at might be like expense growth. So if you're an academic medical center, which we have one in Vermont, UVM Medical Center, how does their expense growth compare to other academic medical center expense growth? So let's say Dartmouth or Albany or wherever it might be, Maine. And you say, okay, well, this is really high. Like what explains this? And you'll have a hearing and you ask them all these questions, or you'll look at the administrative spend. How much money are they spending on what I'll call medical bureaucracy versus patient care, right? These organizations are huge. UVM's about $1.9 billion a year in revenue just for the medical center, not the other hospitals. And so it's a very complex system. Then we also consider what can Vermonters pay? What's happening with the rest of this system? Are they able to get enough money to sustain their operations? What's the impact of giving a 10% rate increase here? How much money is that? What will that do to the insurers? What will that do to the FQHCs? Taking all that information, receive all the public comment, and then the board members deliberate and make a decision. And that decision generally, all those factors go in, but generally what we're deciding is the NPR growth, which is how much revenue.
NPR?
Net patient revenue. Thank you. And that's the total amount of money they can charge or bring in from seeing patients. Now, you do that because we have an affordability crisis in healthcare. And if revenue goes up more and more and more, well, someone's paying for it. And people will sometimes say, well, why do you regulate NPR? And my answer is someone's got to pay for it. And it's either you're raising taxes to pay for it in Medicaid, or you're going to have increased insurance rates. So we want to also influence hospitals to move care out of hospitals. Hospitals are very expensive to provide care, and we want hospitals to send care that's appropriate to these other places because they're cheaper, they're more accessible, and they also have very high quality. So do we want patients going to the ED when they can actually go to a primary care provider? The answer is no, we don't. And so if you cap the revenue, one of the goals is to encourage people to go to hospitals to send patients to the right place. That's easier said than done for hospitals. Some don't have the resources to do it, and some don't have the FQHCs or the independents or whatever it might be around them to send them to. So in the more rural environments in Vermont, that's a more difficult thing to do because there's just not the resources around the hospitals. And I'll share a few that I have formed over the last 2.5 years, which is the Vermont healthcare system. Part of the problem is that surrounding support around the hospitals. A lot of care is backing up in our hospitals. It's unfair to the hospitals. It's hard on their finances. It's hard on payers, and it's hard on patients. And so we've seen a deterioration of the surrounding supports around hospitals, mental health, long-term care, and primary care. And we're not going to solve our healthcare problem without those being adequately supported. And sorry, the other piece of it is that rate. How much more can they charge commercial insurers?
Right. How often do you see, because you said those benchmarks, how often do you see hospitals asking for rates that are lower than your benchmarks? And then how often do you set the rates eventually that ends up being what they ask for or lower than what they've asked for?
I don't have perfect information off the top of my head. I don't believe I have seen, there might have been 1 or 2 this last year where hospitals requested less on the rate than the benchmarks. I think there was maybe 2 or 3 or so, a small handful this year. On the total revenue, the NPR, I don't think we've seen anyone below an NPR.
It's rare. It's rare.
It would be rare. And historically, it's very rare to be under any of the benchmarks and the submissions. In terms of what we approved historically, in prior years, like 2019 to 2023 budget year, we approved, I think about 99 point something % of what was requested in the revenue. I think almost like 99.8 or 9% of what was requested in the hospital budget revenue was granted by the board. And then on the rate requests, it predominantly has been significantly over benchmark up until the last year or 2. So if the benchmark was 3, we'd see requests of 15, 20, 10, 12, way above benchmark. And generally, historically, we've granted significantly above benchmark. There's a pro and a con there. Pro is we've not lost a hospital in Vermont. That's actually quite a feat. We'll get into this, but there's been a lot of rural hospital closures across America. And that part of that is because we've been increasing the commercial rates to help, but that becomes less affordable.
H167. I had to go to a meeting in Randolph or Gifford. The board of the Gifford gave voice to the community that night. And the community said how important Gifford is to that community. They also, Mike Koch, who's the president CEO of the there now, gave a reform on healthcare, which was rooms of surgery care focus, and they did eliminate a couple programs. One of them was the chiropractic one. They're going to give that, outsource that to other places. And I can't remember what the second one was because that's the one thing that I forgot to write down.
Your gynecology.
Yeah, gynecology. Yes, exactly. That was the other one. Then they started speaking, not necessarily him, but somebody else got up to spoke, and I think it was a representative from you guys. I can't remember, about the Oliver Wyman report and how inaccurate it was for the state and how much money that we spent on a very inaccurate resource. And because they came out of the Albany.
So Senator, you're moving into Act 167.
Yeah.
And the Oliver Wyman report. And I think first the board is going to introduce its role and where it is with
Sure.
that.
We'll probably cover.
We are going to invite the Agency of Human Services and the board back in to
Perfect.
do a little deeper dive on both those things, but these questions are good questions for you to share. I'm
Yeah.
not sure that we should have the answer right now until we get to 167, but
Yeah.
I know you're very concerned about that.
Well,
And
I'm.
finish your question.
I'm just speaking for the people in the
Yeah.
community. That's all I'm doing. That's my job.
No, we understand that.
So,
Good.
so yeah, if you have any question,
Sure. We have some of that material in the slides that
That'll be
we'll get
good.
to. Briefly, that it was not inaccurate and it was not a giant expense. It was it's a lot of money. There's no question. I think it was around 900,000 of 1.1 million in total. There was some misunderstanding, I think, about what the data was and what it was used for, but the data was not wrong. There's claims data and there's discharge data. Do a financial analysis, you have to use one database that has claims information. If you want to look at total discharges, it's a different database. Oliver Wyman did a claims analysis, which does not have the entirety of the discharges. But if you looked at the discharge information, you couldn't actually come up with a claims analysis. If anything, the report was the more conservative approach. The finances actually would have been worse if they'd used that other database. So I think there was some confusion in the state on that, and Oliver Wyman addressed it, and they put in a couple footnotes to note this for people so it was clearer. And I wish it had been clearer, but it was not inaccurate. The big takeaway from the report is that the healthcare system is in crisis. Directionally, I don't think we can disagree, or any hospital or anybody can disagree with that. I think that was really the ultimate point. The other thing is there's some misinformation about, hey, they're saying to close this hospital or close that hospital. The Oliver Wyman report was the first step in doing two things. One, what's the financial future of our state's healthcare system look like? Let's get real about that. And number two, what can we do about it? And it created a set of options, a huge menu of 144 plus options for any number of people in the state to address this coming headwind that's very serious. From there, Act 51 was passed in 2023 that empowers the Agency of Human Services to look at the Oliver Wyman report with local businesses and hospitals and communities and make decisions as to how to transform the system. So that's what that was. Yeah, but we can get into a little bit.
Did that help answer your question? a little bit?
it does.
Yeah.
It does. As I said, I was just there. I didn't speak. I was just introduced as this new senator for that area, but I didn't speak, but I did take notes, and it was a concern for the community. And that's, again, we don't, as senators or House of Representatives, as Matt, we represent the people. And when they come to you and they say, hey, this is our biggest concern, we don't want to lose our local hospital.
We represent the people too. Yeah. So we're public servants doing this to represent.
We're all in it
Yeah.
together.
And in that role, there is sometimes a difficulty, a conflict in that no one wants to lose any local healthcare provider, not an FQHC, not an insurer, not an independent, and certainly not a hospital. But then you come back to the question of how are you going to pay for it? And one of the highlights of the Oliver Wyman report that's been happening is a number of hospitals have taken a lot of steps to try and start addressing this on their own, including Gifford and Michael Costa. And we commend them and thank them for doing that. North Country has as well, a number of hospitals. So if anything, I know there's some noise around it, but people are taking steps that are important to shore up the system.
He's the new CEO of Gifford.
Okay, Michael has a long history.
Mr. Koch,
Yeah. Costa,
Costa.
Costa,
COST.
yeah, Costa, yeah, sorry. It was a gentleman named Koch. I got up and spoke.
Oh, sorry about that.
Yeah, he was the guy that got up and spoke. I wrote down his, I didn't write Costa.
Yeah, sorry, I mixed them up. Mr. Costa is the president. and CEO.
Yeah. Seems like a nice guy.
Very nice. Next slide, please. I'm gonna try and go through a little bit quicker because I'm taking one long. I'm sorry, Chair, we have till 10:30? Or how long would you like us to? go?
You have until, a little before 10:45.
Okay.
That's fine. Have another hour and hour and 5.
So Vermont healthcare costs are plainly some of the highest in the United States, whether it be the amount we spend total per capita on each person for healthcare, or whether it's the commercial insurance increases. I'm going to caveat every single piece of data here that there's often some level of noise or difference, or somebody can say something about any piece of healthcare data. It's never that straightforward. So Vermont healthcare plans, QHP plans, have richer benefits. So that can drive some of the cost difference. This slide is intended to show you the increase from year 2018 to 2025 from Vermont compared to national. So the richness and benefits hasn't changed in a way that would cause this. But it's important to see that nationally, the lowest priced silver plan on exchange is not up a whole heck of a lot. Whereas in Vermont, you can see the increase in the spike in our QHP plans. And sometimes people say, well, we're an older state, so that's driving it. But other older states are not seeing this kind of increase either, not even close. The other thing is just, this is one plan. There's platinum, there's gold, there's a different set of plans. All of them directionally look the same as this. This is just one example.
Because we heard in finance yesterday, we have done silver loading, so our gold plan is actually less than our silver plan right now. But if they're all doing the same basic increase, then that's not the cost.
So correct, this year the board voted and approved silver loading, which does make the cost, the benefits you can get for the same price are better.
Right.
So you can pay for silver and get a gold level of benefits. There's a really important point in this. One, this is what your constituents are paying healthcare costs. And this is very, very harmful to our state's goals of improving our demographics. It's hard to keep young families here that are in their early stages of their career when their healthcare costs are this.
Yeah.
It's very hard to increase business and grow your economy when your healthcare costs are doing this. Businesses don't look for states without a control of healthcare costs. It's a dampener on our ability to grow our economy and improve our demographics. It also can have an impact on the care people seek. They can't afford care, that impacts whether they go for care. And that can create sicker patients and not as healthy of a population.
And we went through the plans yesterday and here as well, with no one.
Oh, great. Yeah.
Yeah, so we're trying to do some things concurrently with finance, help us move together. And so Senator Brewer, do you have a question?
I was just going to add to what Senator Cummings said yesterday in finance. Another piece of information that I think is helpful is that we do have an older population, but we also have a healthy population relative to the rest of the country. So again, it kind of flies in the face of background.
Correct. If you have a healthy population, your health insurance costs should be better. And if you have an older population, they are largely, if not predominantly, covered by Medicare.
Right.
So if you can manage your healthcare costs and your healthcare businesses to Medicare, that doesn't spill over commercial costs. One of the problems here in Vermont is we're having a hard time managing our healthcare costs to Medicare, and that it can spill over. It's a regressive tax, is what healthcare costs are. If you raise Medicaid rates, it's borne by people with more resources and it's spread throughout the entire state. When you do it through health insurance premiums, it's a smaller segment of people and it really targets more businesses, frankly. And that's something to think about. Is this how you want to finance healthcare? Through the insurers, who are, one of them is serious financial jeopardy, or through taxes, or do you need to get control of them? My view is that we spend about as much as anyone in the country. There's not a whole lot of more money to add. I don't think you want to raise taxes, and I don't think we want to see insurance rates spike. We also don't want to lose Gifford or any other hospital. So what do we do? Now we'll go to the transformation and some of the other work the state is doing. It's an allocation problem to me. You have a pie of $6.5 billion. Are you using it right? And I would argue that we are not. One other real quick point on this, there's subsidies for individual plans. So this covers small groups of employers and then individuals. Individual market currently has subsidies from the federal government that make this a lot more affordable than it looks here. Those are set to sunset this year. And if they're not renewed and extended, it will really spike enormously people's healthcare costs. And you'll see a lot of people get off of healthcare insurance in Vermont, which is not positive. You can go ahead, Kristen. This just paints the same picture. This is a silver plan and a platinum plan on the exchange here in Vermont. This is the increase in annual premium. So green is platinum and silver is an orange here. You can see for a platinum plan is about $25,000, and as of 2025, we're pushing $50,000. I don't know many of your constituents that can afford $50,000 a year in health insurance premiums for family of four. On top of that, you have out-of-pocket costs, and that's this graph over here. So if you pay 50 grand and you use the doctor and you need care, you'll be paying another $7,000 or so in out-of-pocket costs. Or if you're on a silver plan, or approaching 20 now, plus, is it 47,000 or so? So you're very expensive. No one can afford that. And that red arrow is the trajectory we're on. Next slide, Krista. And we spoke about per capita. That's how much we spend on healthcare per person in the state. You can see Vermont around 2,000 or so was about equal with the national average. Keep in mind, the United States healthcare costs are the highest in the world. And Vermont has some of the highest healthcare costs in the most expensive country in the world. So we're not at where we want to be as a state. And you can see Vermont all of a sudden started seriously surpassing national average around 2001. And this data goes to 2020. There's often a lag in healthcare data. So this is 4 or 5 years behind now. I'm quite confident our gap has only grown and grown significantly. Next slide, Kristen. So what does this mean? What does it mean when you have these healthcare cost increases? One way we see it is in our property taxes. Teacher healthcare costs have risen enormously. That results in either school budgets being smaller or local property taxes going up. I know property taxes is an issue that the legislature is trying to address this year. Part of that resolution also needs to look at what's happening with healthcare costs, because that's feeding a big portion of the increases. The average property tax bill for 25 went up 18.5%. And one of the largest increases that drove that was healthcare costs. Teacher healthcare costs went up 16%. And if our healthcare costs continue to go like that, you'll see this again. You'll see it again. You can reform education all you want. If you're increasing 10, 15, 20% in health insurance costs for teachers, you're not going to abate the problem. Next slide. And this is everywhere in the news. How rising healthcare costs are driving up property taxes. A statement from Governor Scott on additional projected property tax increases. And I just noted here that the fact is, with this projected increase, Vermonters will have seen a 33% increase in education property taxes in 3 years. Healthcare costs are going up way more than 33% in 3 years. Blue Cross last year, I think, was approved around 19 and 24%, 22, 23%, something like that in 1 year.
I talked to them. One of the ladies from there was here, 22% this year.
22%. And for the small group, I think, and then individual was probably 17, 18.
Yeah.
The year before was probably the mid-teens, 14, 15. And I don't think it's going to be lower next year. It could be a little bit lower than that, but it's not going to be 4%. So we're way above national.
Actually, there's a local group in my area of the state working on Vermont specific data and hospital data specifically. Some of this data reflects what they're doing. We might have them come in and talk as well. Yeah.
Kristen, you can go ahead. Next slide. So next, I want to talk about system sustainability. What that means is not losing our providers. We focus a lot correctly on hospitals and whether hospitals will go away. They're incredibly important to healthcare and our communities, but they're not the only piece of the healthcare system that's important to our communities. There's been a fair amount of national attention and news on Vermont's healthcare system and the problems we have. When I first got board, I was sort of surprised by the data when we all started digging in and trying to understand what was going on as a group, as an office. And I think the system was a lot more strained than previously understood. And at this point, you have national organizations like Kaiser Family Foundation, a very reputable national organization that studies healthcare and healthcare costs. They did a big story. They came here in Vermont, they interviewed a bunch of people and did some reporting on the situation that we have here in Vermont. And this goes to Senator Gielic's point. Vermont consistently ranks among the healthiest states, and its unemployment and uninsured rates are among the lowest in the country, among the lowest. Yet Vermonters pay the highest prices nationwide for individual health coverage, and state reports show its providers and insurers are in financial trouble. 9 of the state's 14 hospitals are losing money, and the state's largest insurer is struggling to remain solvent. Long wait times for care have become increasingly common, according to state reports and interviews with residents and industry officials. So you want to keep your hospital solvent, you want to keep everyone else solvent, but you have no more money to do it with. That's what that says. You go to the next slide. Financial Times is an international, highly respected publication that studies financial markets, amongst other things. They have one of their lines of business is the healthcare specialist. Financial Times ran a series of 3 articles on Vermont's problems and challenges. And they noted in this piece from, I think it was September, August, October, somewhere in there, Vermont's healthcare system is teetering on the brink, and Blue Cross Blue Shield of Vermont risks becoming its latest casualty. That may seem surprising considering the Green Mountain State has the highest premiums in America. Still, they're not enough to keep Blue Cross Blue Shield of Vermont and other major insurer, MVP Healthcare, afloat without staggering rises each year. In fact, Blue Cross Blue Shield of Vermont just received approval for 22.8% in small group and 19.8% jump for individual plans after a startling decline in its reserves. I often get questions, why are you giving them 22%? We can't afford it. And that's exactly right. We cannot afford it. But you look at Blue Cross's reserves, that's how they pay for claims. They have to be able to pay for claims. And historically, they had quite a bit better reserves. There's a thing called RBC, which is a measure of how much money they have. And DFR, or financial regulation, sets a guidance level. I'm getting it wrong. I think it's like 600 to 750%, something in that range. Blue Cross, as of this publication, is at 327. Okay, so way below DFR's range. And since then, it's declined precipitously. It is far below 327 at this point.
And DFR is?
Department of Financial Regulation. They're the solvency regulator for the industry, insurance industry.
We were told yesterday by Blue Cross that for every $1 they took in premium, what it was last year, the latest number they have, they paid out $1.11.
Yeah.
So that 11 cents is coming out of their reserves. They're going down.
Right. So if we do not approve, we don't want to give big approvals. Our job is also affordability. But in this year, if we did not, they would be in a worse financial position. And if you lose your largest insurer, if it goes insolvent, providers don't get paid. And it's destruction to the healthcare system. If you think about some of our organizations, I'll go through some of the data quickly. They have days cash on hand. And so if you miss payment for a week or a month, or you have an insolvent insurer, you're bankrupt. You can't pay your people. You're going to lose out QHCs. You're going to lose independent providers. Some of the hospitals with more cash on hand will be able to handle it longer, but you don't want to put them in that position. And then how you get out of that is, I don't have an answer to that.
That goes for individual providers as well, you know, hospitals and providers. I've lived through that with my husband in his office, and it's just like
Absolutely.
terrible. Yeah.
Yeah, they don't get paid. They have to pay for leases on their equipment. They have to pay for the building. They have to pay for their staff. They have to pay for nurses, everything. So
Insurance.
yeah, their insurance. We'll get to that. Next slide, Krista. This is also from Financial Times, the health payer specialist. Oh, here it is, right. So Commissioner Gaffney noted that the state requires insurance companies who operate in the state to keep somewhere between 590 and 745% of expected spending in reserves. However, the Vermont insurer, the state's largest 66% of the market, has not been able to do so since 2019, when its reserves fell to 567. And then currently in 2023, it was 337. And it's far, far, far lower than that now. So it's just a straight decline. My point here is there is not some magic pot of money to go and create solvency for Gifford or North Country or Porter or anybody. We have to find a different path because the money's not there. You can go to the next slide, Kristen. So what's causing that? We have historically been a very healthy state, one of the most active states, and that's a great thing. The hospitals I'm speaking with have, for about a year now, indicated that population health, the acuity and utilization of healthcare is spiking enormously. So the health that we had is not it's not there anymore. It's deteriorating. Our people are not as healthy. If you talk to Blue Cross or UVM, they'll tell you that the acuity, the illness of the patients is going up significantly. And the amount of procedures and volume they're seeing is going up precipitously. So many Vermont hospitals have extremely high commercial prices. We often look at it as a percentage of Medicare. Medicare intends to pay about 100% of the cost. And then commercial often, very typically pays above that, sometimes a multiple of that. And we measure hospital costs as a multiple of Medicare. That's one way to look at it. So some of our hospitals are up over 300% of Medicare, whereas national average is 250-ish. So if you have high prices at hospitals and all of a sudden utilization goes up and acuity goes up at high prices, you have huge amounts of cost. And Blue Cross's financial insolvency is driven in part by that increase in acuity and utilization at high prices.
Is there an explanation as to the rise in acuity? Is it because people have high deductibles and they're avoiding care early on, or is it something else?
It's hard to pinpoint one specific thing. We don't have great answers on that. I think that could be a part of it for sure. But how much of it is driven by that versus other environmental factors is difficult to say.
So I'm writing down questions that I have for you, and one of them is to talk at some point about population health outcomes and how that's utilized in your decision making, and then how you measure quality and outcomes for that. What is it that the board does, or how does the board measure quality outcomes, and how does that inform decisions? So you don't I don't know if you want to answer that right now, or I think probably best to let you keep going.
Okay.
And I have another set of a couple questions as well. So just, I think, keep going, and then we can go back to that.
Okay. There are two primary metrics we look at for hospital financial health. One of them is days cash on hand. You want them generally between 100 to 180 days cash on hand. 120, 150 is a pretty comfortable range. Over that, they might have a little bit too much cash. You have 300 days cash on hand. That's a lot of money in the system that's in a bank account or investment account. So 120 to 180 is pretty comfortable. 150 is pretty comfortable. You can see the decline in Vermont hospitals' days cash on hand from 2017 to 2025 budgets. So we don't know what 2025 will land at, but this is what was budgeted system-wide. So it was 192 in 2017, and it has gone down to 125. These two blips in 20 and 21 were really from COVID funding. Federal funding has gone away. I would ignore those as anomalies, and the trend line is very clear. And in 22, 23, 24, 25, that has coincided with large requests for rate increases. The rate increases are a big driver of helping get that number higher, but it comes at the cost to all the businesses and the people having to pay. And I think my point here is we can't pay our way out of this. We can't commercially raise insurance costs to pay our way out of it. We've been doing that, and it's not working. It's helping a little bit in buying us time as to sustainability of hospitals, but not sustainability for the rest of the system or our insurer or our people.
Right. Also coincides with some legislation that we passed asking hospitals, and working with the board, asking hospitals for sustainability plans. And so that was slow in coming, and hopefully the next steps will help.
Yes, there was.
160.
I can talk a little bit about that.
Yeah, we'll get through that. One big note here is, and it's hard to understate the disruption of COVID on our provider community and what they had to do to take care of the community when that happened. Next slide.
Just a quick question about the last slide. So when you were first talking about it, you mentioned how having too much, there was like a possibility of too much cash on hand, and that might be a bad thing. Or did I misunderstand you a little bit?
I'm sorry, Sid?
Or did I misunderstand you a little bit?
No, I mean, there's a point where there's, if a hospital's 500 days cash on hand, that's money that's not being utilized elsewhere in the system. I would view that as bad. 200 days cash on hand isn't necessarily a bad thing. It's a lot. It's very healthy. But you're also, that money isn't elsewhere in the system.
Right.
So there's a balance. And I think 150 is cash on hand is probably around the right area, give or take. This is not an exact science.
I think I can just jump in here. I think when we look at days cash on hand, and if we're seeing a hospital that, for example, might have a lot of days cash on hand, 300-400, we might also then look at what are their prices. And if their prices are extremely high relative to the benchmarks and they're generating all these days cash on hand, that might, give us pause and suggest an adjustment in the prices. So I think it's often looked at in conjunction with other metrics.
Then the other main financial health, or there's many, but one of the main primary financial health metrics to look at is operating margin. That's how much money the hospital is making off of its operations of caring for patients. Hospitals can make a lot of money in other ways, investment accounts. That days cash on hand is usually held in some type of investment account. So they can make a lot of money there, or a pharmacy. They might run a pharmacy and they can make some money there, wherever it might be. But one of the ones we look at is operating margin. Total margin will be better than these numbers, but we want them generally 2-3% is a pretty nice spot for a hospital to have for an operating margin. Negative operating margin means you're losing money on providing care and you're eating into your days cash on hand, or you need larger rate increases. So that's difficult. And the red numbers represent negative operating margins. And you can see in the last several years, 22, 23, 24, there's a lot of red across a lot of hospitals. Some of them deep in 22. -6, -10, -4. Those are really, really deep negative operating margins. And it's gotten a little bit better in 24 as the system has improved a little bit, but that had come at the cost.
If I could just want to point out, it is looking better in 24, but if you look, CVMC, Copley, they are teetering on 0, right? So even though they're not red, it wouldn't take much for Scotney, to be in the red. Yeah, Springfield. So they're pink. Can I call them pink? They're pink. So.
Next slide, Kristen. We're speaking about the financial support that has come through. So the state goal in the all-payer model, the prior system-wide healthcare reform the state endeavored in 7, 8, 9 years ago now, was that we would have revenue growth in healthcare spending between 3.5 and 4.3%. So that sort of matches inflation. So that was the goal in the all-payer model. If you compare the amount of revenue growth in the Vermont hospital system against that all-payer model growth target, 3.5 to 4.3, you can see that we've gone quite a bit above that. So this blue line, actually ignore the blue line for now. The orange line is this one. 3.5. It's 3.5. That's the lower range of the all-payer model goal. So you can see in 24, we're way above in hospital revenue growth as compared to that goal range, quite a bit above. And then if you go to the higher range, that's the green, we are significantly above the green range. So we've been putting in a lot of money to try and make sure that we have the access to care and the sustainability that we all want. But again, who's paying for it? And that's really the hard part of this. Over here on this little chart, you can see how much above those target ranges we are from fiscal year 17 to fiscal year 25 budget. At the lower range, we're $483 million above our goal range. At the higher end, it's $278 million. But as these financial headwinds continue to hit hospitals, this will continue to be what we have to do unless we make some changes or do something different as a state. You can go ahead, Kristen. Vermont is not alone. This has been a national trend for years. You're seeing hundreds of hospital closures and service line closures across the United States. Vermont is one of the few states that has not actually had a hospital closure in the country. And we should be proud of that, but we need to recognize that that's going to be difficult to do with the way we've been financing it and paying for it. This is from Becker's. So Senator Hart, you mentioned, some consternation about the Oliver Wyman report and disagreement with it. This came out shortly after. I think Oliver Wyman came out mid-September, and this is November from Becker's, a very well-respected national healthcare reporting service. And Becker's found that 705 hospitals were at risk of closure. And Vermont was one of the states with the most hospitals at risk of closure in the country. I think the Oliver Wyman report indicated there are 4 hospitals at very serious risk of closure. And this actually found as well, totally independent of Oliver Wyman. I don't know if they'd ever heard of them. And Oliver Wyman's an organization, a big consulting firm, not a person. But they found that 4 hospitals were at immediate risk of closing in 2 to 3 years, and 8 hospitals were at risk of closing across the state. I'll just say on the Oliver Wyman report, and Member Holmes will get into it, but there's a lot of recommendations in there. Some that I agreed with very, very strongly, and some that individual members did not agree with. It's 144 plus pages of recommendations. It's very hard to get 5 people to agree with all 144 of these things. Some are totally correct, and I think critical to do, and some I was not entirely understanding the thinking or exactly the recommendation. That doesn't mean I'm right. It doesn't mean they're wrong, but that's just how it works.
But the value of that report was really consolidating the concerns that exist across the state within regulation, within policy, and support services. So it was extremely helpful. And there are some recommendations that you'll probably talk about better.
Yeah, I agree. I think it's a great resource for the state. It has been for us in looking at what we do and how we do our work to have Dr. Bruce Hammer, who did it, has helped countries design their healthcare systems. He's a doctor. He's done this for 60 years. Having his input and fresh eyes, we get a little parochial sometimes, and I'm guilty of that. We're not always that special, and sometimes having that outside view is helpful. It helped the board, helped me, help Jess, I'm sure too. Next slide. I'll go through these. I probably put in too many, but briefly, the FQHC. So we talked about the hospital's financial problems, the insurer financial problems, but I don't want to ignore the primary care, which is largely delivered at the FQHCs in Vermont. They're in a real financial crisis. Lamoille, which is a very important practice in Morrisville and Stowe, is in serious financial jeopardy. Serious. This is Little Rivers and their operating margin, and you can see it over time. From 2015 to 2022, 2023, just completely erode. Again, there was a blip there for COVID funding, but completely erode. If they're losing $2 million or even $500,000, they're not going to survive. Now, I'll tell you why they're having this problem. It's multi-factor, but one of them is their healthcare costs. And the cruelest of irony, our healthcare costs are destroying our sustainability of our healthcare providers. So they're often on the exchange or self-insured, and their healthcare costs have gone up over 60% in 5 years. So if they don't get a rate increase from Blue Cross Blue Shield or whoever the insurer is that helps them pay for that, this is what happens. Their healthcare costs go like this. Their healthcare premiums payments that they're getting, reimbursements, are flat. It causes this. This is their this is Little River's premium costs per month per employee. And you can see how much their premiums have gone up from 2018 to 2024. So I spoke with the Howard Center, an incredibly important mental health provider. One of the most important resources we have in the state right now is we have a mental health crisis and a substance use challenge. And they provide a lot of important services. When I met with them, I think they said they had 5 or 6 days cash on hand, and their health insurance premiums have gone up over 100%. They can't survive with that dynamic.
Are you going to talk a little bit about what factors go into these costs that we talk about? Because it'd be nice to know. Thank you.
There's many. So if you look at why are healthcare costs going up so much, you can look at the hospital health insurance costs of providing care, and then you can also look at like what's driving premiums. The biggest drivers in Vermont on why our premiums are going up so much is really 3. 1, it's hospital prices. 2, it's hospital utilization and claims, just how much money. This is not negative. They're serving their patients, but that comes at a cost. So if utilization goes up at hospitals at high prices, that drives healthcare costs. Another big driver is prescription drugs. prescription drugs are a huge driver of those insurance premiums. And that is one that no one has been able to wrangle in the country, and one that we don't really have good control over, actually any control over here in Vermont.
Are things like inflation, supply chain, workforce, are those also part of the cost drivers?
For sure. So if you look, so why are the hospital costs so high? That's one of them. And some of it is simply the cost of what they're buying. Insulin costs, surgical gowns, you name it. Those are going up pretty significantly, so they have to pay those. The price of
What's the differentiation between medical inflation and inflation consumer price?
there's different indices.
Okay.
That
I mean, just big difference.
they haven't been that far off in the last couple of years.
Is that right?
Yeah, they've been relatively within a point or two. So I think, I don't have the numbers here, but I think medical inflation was 2 to 4% last year. I'd have to get you that number. I shouldn't say that number for sure, but it hasn't been a giant gap. However, our expense growth in Vermont has been very significant.
Yeah.
And some of that is cost of nurses. Right? It takes a lot of money to hire really great nurses, and I think it's money well spent. My wife is a nurse, and they work really hard, and they do a great job. We need them, we need more of them. It costs a lot of money. So yeah, a multitude of factors go into it. But I would say healthcare costs in Vermont are largely driven by prescription drugs and hospital costs. And again, that's not to say the hospitals are to blame for it. Some of it is just, this is what they got to do. Nonetheless, still have to find a way to pay for it. Go ahead, Kristen. And again, this is Little River's days cash on hand. They're down around 5, 6, 7 days. So very fragile. Next one. This is Community Health Centers of Burlington. Same story. They used to be about 140 days cash on hand, 145 in around April of 22. They're down to 62 2 years later. And you can see the trajectory. That's not abating.
We'll be keeping an eye on the FQHCs during the appropriations process very closely.
Yeah. So primary care is one of the most important pieces to our healthcare puzzle, because that allows you to get the checkups you need, it allows you to catch the issues earlier that the Senator Gillis was referring to, and allows you to get patients out of ED rooms. If you don't have enough primary care, you have a healthcare system that's going to be challenged. Next. Again, this is community health centers and their losses, their financial losses. For 2025, they're projected to lose around $2 million. Last year, they lost $650,000. And again, you just can't sustain this. We're going to lose these resources pretty quickly if we don't make changes. And if you have a nearly insolvent insurer, you can't bail it out with money. Next. And then next one. I'm going to take Jess to talk about Act 167 and the transformation work. Member Holmes and the board members in this legislature, before I was here, recognized the problem that we had brewing, and it was very serious. And then the legislature supported that investment in that Oliver Wyman work to try and find a path. So Member Holmes led our transformation work from the board.
Thank you. So I'm not going to belabor this point because I think, Chair Foster has outlined pretty clearly both the affordability crisis that we're facing and the sustainability crisis that we have. The board has been very concerned for a while. As you can see, these operating margins on the left, these are hospital operating margins. The middle line is the system as a whole. The bottom line is the system without UVMC, and the top line is UVMC alone. But you can see the decline was precipitous since about 2015. And then in 2019, we did have our first hospital experience a bankruptcy. So, if we think about these declining operating margins, we look at dwindling days cash on hand, and we saw hospital bankruptcy. We were very concerned, all kinds of red flags at the board, and I think a series of actions by the legislature, a lot of them coming out of this committee. Thank you, Senator Lyons, and the Green Mountain Care Board and AHS trying to figure out what we can do about the sustainability crisis. So this is a history of kind of where we've been and where we've been coming. Since about 2019, we've been working on this. So we've been working on this for a while. Back in 2019, the GMCB convened the Rural Health Services Task Force. This is a group of members of stakeholders across the state that were really convening to try and find recommendations to improve sustainability. Recommendations came out around workforce. They came out around revenue stability, increasing Medicaid rates to ensure the stability of our system, looking at telemedicine as a way to improve access, things like that. At the same time, that was the year that the Green Mountain Care Board in its hospital budget orders required 6 of the 14 hospitals that had experienced a negative operating margin year after year to come forward with a sustainability plan. As Senator Lyons mentioned, that was the first year we did that. And then in 2020, the following year, we extended that requirement to all the hospitals, saying we all, the trajectory is downward for all these hospitals. We need sustainability plans for everybody, please. Unfortunately, we had to put a pause on that mandate. 2020, we should actually have a big kind of disclaimer in there. COVID hit, and obviously all the hospitals, and rightly so, were focused on the public health emergency. And so requiring them to come up with a sustainability crisis when they were looking to deal with the pandemic was something that was beyond what they could handle, understandably. So there was a pause on that sustainability requirement of hospitals, but the legislature passed Act 159 that required the Green Mountain Care Board to come forward with some sustainability interventions to try and shore up the system. So in 2021, then we worked on that and we provided a set of recommendations to improve, both the sustainability and the affordability of the healthcare system, predicting in that report that without significant intervention, hospital financial health would deteriorate, affordability would decline, and we worried about essential services being cut. That was back in 2021. We're seeing it happen now. If you read the news, exactly what we predicted. Sadly, we were not wrong. But the report did call for funding for a very community engaged redesign of the delivery system to think about how do we right size the system? How do we reduce inefficiencies? How do we find ways to lower costs and improve quality through looking at the infrastructure? And so in 2022, then with those recommendations, the legislature passed Act 167, which has been referenced a couple times already today. And sections 1 and 2 provided those very, very necessary resources. Thank you again to this committee and others in the legislature that funded this very comprehensive, community engaged process of healthcare redesign. Really a full scale, I would say, diagnosis of the system disease and trying to find strategies for treatment. And that extensive process of 167 took us through 23 and 24. If you can move to the next slide. So this was the process. This is an Oliver Wyman slide. This is not a Green Mountain Care Board slide, but it was taken from the report to outline that process. So the process basically started. It was a requirement of Act 167 that the board, in collaboration with AHS, conducted a data-informed, patient-focused, community-inclusive process to reduce inefficiencies, lower costs, improve population health, reduce inequities, and try and find ways to increase access to essential services. The process started in August of 23 with huge community engagement. Literally thousands of stakeholders across the state were engaged, hundreds of meetings, one-on-one conversations. Every single hospital service area had 2 to 3 meetings in each one to try and gather information from communities about needs, about unmet needs, to gather insights through data to try and understand, again, what is the problem and how can we move forward to find more sustainable path, more affordable and sustainable path. The report was worked on through that entire year, and then in September of 2024, the Oliver Wyman team that was basically facilitating this process that Chair Foster mentioned, delivered that report. And I just want to actually talk a little bit about Oliver Wyman and the team. Dr. Bruce Hamre, who led the team, is actually known to the state. He's an infectious disease doctor. He's led hospital systems. He's the CMO of Geisinger Health System, which is a very well-renowned healthcare system in Pennsylvania. And he was the leader in responsible when we were going through the COVID pandemic. He worked actually with the state on risk assessment and preparedness. So we had a history with the state and elsewhere. And he and his team really did incredible, I would say, work trying to talk to literally everybody and anybody who was, could, give some insights into our healthcare system and its weaknesses and potential opportunities. So where we're at now is we're kind of in, oh, that's a great slide. Sorry, Kristen, go to that slide. This just gives you a sense of how many people he spoke to, how many people he and the team spoke to, literally over 3,000 participants in very, very many meetings. It's a pretty comprehensive process. I don't think any other state has tried to do such a comprehensive community engaged process as Vermont. I think there's a lot to be proud of. A lot of voices were heard. I heard your point, and I think there was efforts and attempts to really seek public input at every stage of that process. You can go back one slide, Kristen. So where we're at now is we're kind of in this green zone. The green zone is now where the Agency of Human Services has taken on the leadership role of taking that report and thinking about where we want to go forward, in particular, where we want to go forward with hospital transformation. So that's kind of where we are now. I'm going to go, you can go 2 slides up, Kristen. Okay, this is one of the slides that came out of the report, and I just wanted to highlight it because, to Owen's point, one of the big aspects of this report is to take the temperature of the healthcare system and project forward. If we do nothing, what is going to happen to our hospital system? Each one of these very, very colorful lines is a hospital, and it's a hospital projection that's going out from 2023 out to 2028, and where we think the operating margins will be if we kind of stay the status quo. This is a slide to me that's a call to action to all of us. If we do nothing in the next few years, we're going to have most, if not all, of our hospitals in deep in the red, out of the pink, as I was saying earlier, deep into the red. So we have to do something. And this was a high alert, I would say, slide for all of us to be considering. And the assumptions that are behind this are reasonable assumptions about what expected expense growth will be and what the state can afford in terms of revenue growth at the hospitals. Okay.
Could pause one thing?
Yeah, please.
So the state demographics and housing are a huge problem in healthcare, and that's some of this committee's work, but I'm sure you're all going to be looking at it. As how hospitals are generally financed is they make a lot more money on commercial. So if you have fewer people on the commercial market, you have less people to pay those higher rates. And as we age, you're seeing more and more people go on to Medicare, which doesn't pay as well as commercial. So if we continue to age, and we will, and we are, that's part of the driver of that problem, right? And so what we're trying to do as a board and working with hospitals is how can you run on Medicare? How can you run your operations on what Medicare pays as opposed to Medicare plus 300% commercial? Because that commercial market's going away. It's dwindling.
Yeah, no, I think that's a really valid point. I mean, up until this point, I think hospitals have been filling the gap. Medicaid does not cover often the cost of care. Medicare theoretically is just about covering the cost of care, and commercial is often above that Medicare rate, offsetting some of the less than care cost of Medicaid. And so to the degree that we have been plugging that gap and that public payers have not necessarily been keeping pace with inflation, it's been through commercial rate and through commercial ratepayers. They're a dwindling subset of the population. There are fewer and fewer commercial ratepayers. And as their premiums grow, that not only because it's aging, but also because it's becoming less and less affordable to have health insurance, that's going to be dwindling. And so our ability to kind of close the gap and get from red to black through commercial, it's not happening anymore. We cannot afford the healthcare system that we have with the financing system that we've been using. And I think that's what this red, big, huge, very colorful, but lots of red diagram is telling us. And if we don't engage in meaningful redesign of our healthcare system, market forces are going to take over, right? And if they take over, margins are going to plummet. Hospitals are going to start reducing essential services. They're going to reduce the low margin services, primary care, mental health, things like that, or they're going to close altogether. And we're going to have an access problem more than we have now. We already have, we haven't talked about that. Maybe that's a topic of another day, but people are waiting very, very long to see specialty care, to get into the care that they need, to get into a primary care practice. And that's only going to get worse if we don't do some serious systemic design. So if we go to the next slide, Kristen, this is again from the Oliver Wyman report. Oliver Wyman offered numerous, as Chair Foster said, 144 pages. And this is not a topic of all of those pages, but offered numerous recommendations for the legislature, for AHS, for the Green Mountain Care Board, and for each hospital across the state to think about options to consider to try and move us in a more positive direction. For the legislature, that's on the left. There was, focusing on housing, focusing on EMS transformation. It sounds like that's an agenda item already for today. Increasing broadband coverage, looking at professional licensure to help through the workforce shortages that we have, and looking at AHS structure. For AHS, that's the middle column there, engaging in, and they're taking the lead here and engaging in significant hospital redesign to start thinking about how do we reduce low productivity, increase efficiencies, how do we bring down costs and prices in hospitals, how do we move to more regionalized centers of care, centers of excellence that can be lower cost and higher quality, thinking through that. Thinking through EMS professionalization or regionalization, looking at care coordination for heavy utilizers. There was a recommendation about optimizing and implementing a statewide EMR. So that was sort of in the bucket for AHS. And then for the Green Mountain Care Board, they had some recommendations for us, permitting no further increases in commercial subsidization for those hospital financial shortfalls. In other words, stop using commercial rate to plug those gaps. Licensing any further hospital-based outpatient department units, simplifying and shortening that CON process, encouraging some of these low-cost freestanding diagnostic ASC and birthing centers, moving to reference-based pricing. That would be actually an intervention. Maybe Chair Foster will talk about that to basically bring hospital prices down closer to Medicare rates. And then the last one was requiring all hospitals to use the same accounting agency when they're submitting their budgets so that we have more apples to apples comparisons when we're getting the data from the hospitals. So those are some of the key recommendations. Kristen, if you can go to the last slide, and I'm not going to spend any more time on, is there another slide, Kristen? Yeah. This is just looking at,
You have a question?
oh yeah, sure.
Sorry, hold, I have a comment, you have a question.
Yeah.
Okay, on the last slide, sorry, Kiki.
Sure.
Let's go back one.
No, it's Kristen.
Kristen?
Kristen.
Yeah.
She's on Zoom.
Oh,
She's
so confused.
like working full time back.
Kristen, can you go back one? Okay.
Yeah.
That last 6 on the Green Mountain Care Board,
Right.
require all hospitals the same accounting agency and method to construct hospital funding. Okay, that is interesting. What, can you give us a real short description of what is now being used?
Yeah, every single hospital. So we put out guidance every year and we request information, different metrics for them to submit, different, aspects of their submission, and hospitals interpret things differently. And there's gray area in how you're going to interpret lots of things. We ask for a lot of information. And as a result of that, what we get in is often very varied. And even though we're trying to put a fine tooth on sort of defining different metrics and different aspects of their budget, it's very, very difficult to get a consistent submission across all hospitals. And so this was this recommendation that there's a lot of variation in what we're getting. And if we're really truly trying to look across the hospital system and make valid recommendations or valid decisions about their budgets, we really need to have all the same information coming from the same source with the same definitions. So that was a recommendation to do that.
Amazing, thank you.
Yeah.
Yeah, and a lot of these, yeah, it's a good question. A lot of the work that's embedded in these recommendations will be sort of collaborative work between the board, hospitals, and AHS. And as Jessica mentioned, a lot of it will fall on this table or down the hall or some other committee. So we will be looking at FROG, EMS, EMT, CON, and medical records, EMR, electronic medical records in here. So we have some bills that will relate to that. None of these is simple, not one, but there are some that might be more advanced out with folks with AHS, with Green Mountain Care Board that move a little faster and smoothly. We'll see.
Absolutely. And so this actually, I'm not going to spend too much time on this. I just wanted to include this slide because it does talk about the need to some degree, clarify the roles of AHS and the Green Mountain Care, but in particular, it's going to be challenging. It's going to be difficult. But, you know, one of the recommendations they had in the Green Mountain Care Board was adding a division of planning and effectiveness, really thinking through intentional design of the healthcare system and monitoring progress on, you know, hospital transformation, monitoring access, monitoring quality, monitoring those things and, you know, we're going to need more significant resources to do so. But given the state we are in right now with our healthcare delivery system, in my opinion, I think in Oliver Wyman's opinion, that is money well spent. So I'll put it back over to you.
I'll just comment really briefly on that last one. I do think that the state needs a statewide healthcare plan. What are we moving towards? What is our goal? If we have no more money, how are we allocating the pie? And what's the optimal allocation of that pie for our aging population? We know we need more long-term care. We know we need more mental health care. We know we need more primary care. So what we're doing as a state consistent with what we want? If you look at the data, it's not. We're not allocating the money consistent with how we should be in the state. So I do think that there is an important role for somebody to come up with a plan for what that looks like. Oliver Wyman recommended that be done at the board. I think personally, there's pros and cons to where you do it. You could have it done by the legislature. You could have it done by the Agency of Human Services, Department of Mental Health, the Care Board. And I think there's pros and cons to wherever it's done. But I do think it needs to be done.
And we had this conversation. I had a conversation with Chair Foster yesterday regarding this and have had similar conversations with others, as I think we probably all have. And so there might be a conversation around this table. We can send people out and bring us back the best recommendation for moving forward on the plan. I mean, we already have HRAP, Health Resource Allocation Plan, that feeds into your decisions. But it's broader than that with community services. Just
Right.
How do we do it? Yeah.
Exactly. Because if we lose any of these providers, whether it be a hospital or the Howard Center or Little
Right.
Rivers, it's very detrimental.
Yeah.
Just want to speak briefly about healthcare reforms. There's often efforts to change it and fix it. And the state has been very innovative in some of those efforts. But it's very hard to implement a reform and have it perform like you had hoped and anticipated when you go and do it. So the state first sought to move to a single payer model. That effort ended up not getting to the finish line. That was an effort by the Shumlin administration that we didn't pass. Then the state moved to the all payer model, which is ending this year. That's an accountable care organization model where it's really essentially being accountable for the spend. If you're below the spend, you can get some money back and Fed save some money. That didn't work as we had hoped. We did a return on investment analysis that found that for Vermont payers, it did not work. We lost money on the all payer model. So sometimes people say, oh, we saved money, but who are we saving money? That's the important part. Did we save Medicare money or do we save Vermont Medicaid money or commercial money? Of the three, I would like to save commercial and Medicaid more money than Medicare, since Medicare is a national program that's funded by the entire country and not just Vermonters. So during the all-payer model, we saw a leveling off of our Medicare money. We were getting lower increases on Medicare spend than we were previous to the model. And we saw enormous spikes, as you saw, in the commercial increases. That is not what we're trying to do. It's the opposite of what I think we should be trying to do. There's a lot of lessons learned in that model about how we structured it, how we implemented it, how we resourced it, and how we monitored it. There's a lag. I don't think we knew that it wasn't performing as we wanted in close proximity in time. It takes a year or 2 years for healthcare data to come through. So you can't all of a sudden change. The other thing is there's a bunch of what I'll call free money from Medicare for the Blueprint and SASH and some support for primary care. Incredibly important dollars. But politically, you almost can't leave the model because you can't leave those providers in a lurch, right? So we had this good money that was tethered to this program that wasn't working very well, and we could not leave the model. We did not ever leave the model until it terminated. So it's sometimes we have really good ideas and ambitious goals, But if you don't execute them well, I don't care how good the idea is, it would fail. And I think that's the most important lesson. We can't predict what's going to happen. It's really hard to anticipate all the unforeseen consequences to what we do from a policy point of view. It takes incredibly good monitoring and forethought to execute well. I actually think the ACO model and the LPAR model was a pretty good idea. I kind of like the idea, but it did not work. It did not work at all.
For a lot of reasons.
Many reasons. Many reasons. There will always be many reasons. So there's a couple issues that will come up, I'm sure, in this committee and throughout the building this legislative cycle. One is the AHEAD global budget model. Another is a report the Care Board did on reference-based pricing. And then there are other reform efforts out there. I'll just touch really briefly on two of them. The AHEAD model, the governor signed it last Thursday for cohort 2, and then the Care Board voted 3-1-1 to sign it as well for cohort 2 with a series of conditions that we felt were necessary for the model to be implemented well. I can tell you why I voted for it. It was difficult to get 3 votes. There was not a clear path, and there was not any hospital public comment supporting the model at that time. However, it is a potentially beneficial program, and there's a change in the federal administration, which could have impacts on the federal supports for various programs. So I voted for it to keep the option open. If it's shown to be the best option that we have, it's there if we want it. But it has risks and it has opportunities. And like I said, predicting the future, good luck. So it's a cap. How it works is a cap on how much money Medicare will pay to hospitals and to the state. And that cap is set higher than where we currently are. But if utilization goes up, we're not getting as much money as we would be in fee for service. If utilization stays flat, we could end up with more money. But that's a very hard prediction to make. And these things are costly. You don't flip a light switch and all of a sudden hospitals can do it and the state can do it. It takes serious investment, as we saw in the LPAR model. The other report that we submitted was a reference-based pricing report, which was legislatively mandated. And what that looked at was for the state employees and the teachers unions, how much money would they have saved in their plans if hospital prices were at a lower level. So we spoke earlier about how some hospitals in Vermont, mostly the larger ones, have very high commercial prices as a multiple of Medicare, Medicare being 100. So if you moved our prices currently at hospitals to a lower level, how much would those two plans save? I think it was about $400 million over the study period. I don't have the report. We can send it to you.
We had it.
Yeah.
Yeah, we had.
Now that's a consideration. You could save a lot of money. It would help with the solvency of those plans, as they're also bleeding money at this point. But you're talking about taking money out of hospitals. If hospitals have 300% prices as opposed to 250, they have a lot less money. And how do you maintain the solvency of those? And some of them will actually go up in price. Some will go down significantly because they have variation in how much they get paid commercially. So that's another policy option that's been out there.
I should probably know the answer to this, but I'm gonna ask it. I'm still trying to process, but is reference-based pricing and the AHEAD global budgets, are they mutually exclusive?
Really good question. I think the answer is yes and no. You could do them to, yeah.
So, yeah, so we're going to invite some folks in to talk about just that, just
Okay.
what all those pricing
Okay.
and the economics of healthcare.
Okay.
Yeah.
You could theoretically do reference-based pricing to formulate a commercial global budget, and then Medicare has its own. So you could use a reference-based pricing mechanism in that commercial piece.
Mhm.
The way the AHEAD model, what was signed, is structured is that there wouldn't be a commercial plan in until the second year. And it would just be one plan. So it could be just a hospital self-insured plan. So you also want alignment of all these things, because having professional services budget, Medicare budget, a Medicaid budget, 10 different, it gets very expensive and cumbersome and to do all that. So I think I'll pause there. I think that's all we have for today.
Oh, that's great. Good timing. No, perfect timing. It's very good. So questions now, I think. There are a lot of questions.
You had yours.
Yeah, no, I do have one that I will ask the population health one in just a minute, but. So you were talking early on about the narrow scope of your regulatory authority and what, if any, how would you increase that scope or change it? What more would you regulate? How would you regulate it? What do you see as probably the best regulatory environment?
To be honest, I want to narrow our regulation. We can't do what we have and we can't do it well. We can do some things exceedingly well, but prioritizing all this work is exceedingly difficult. I'll give you a sense of scope. So just the hospital budget process, which we did this summer while we were doing all those 100, 200 community meetings, whatever they were, we were doing 14 hospital budgets for about $3.5 billion. We have to make decisions on those budgets in about 2 months, two and a half months. Going through, I mean, these are very complex budgets. If you look at UVM's budget with a network, with 3 hospitals, with New York hospitals, it's incredibly complex. So if you're going to do it well, you need time and you need resources to do it. Our health systems finance team is 3 people, 3. And then the board members do a pretty heavy lift, and it's getting heavier and heavier as we go. But we can't do it all. So I'm actually seeking to regulate less. Because we can't add the value that we need to add where we want to add it. So if you look at our hospital budget program, with the time that we have and the complexity of the budgets, we don't have a defined quality program to which we regulate to. And we're not going to come up with it in the next 6 months or 12 months. We look at national data, we look at Medicare fines, there are things we look at, but we don't have a defined structure for that. We also don't have a population health metric. We don't have an affordability metric. We don't have an access metric. Those things don't materialize without significant work. We tried to do an affordability metric. We worked on it for about a year with the stakeholders, and everyone disagreed as to what it should be. So as of today, we still do not have an affordability metric. But we do know we have general guiding principles about what can you pay and what are the targets and goals. So it's really complex to add these things.
Yeah, so but having principles in place or a plan in place, if we had a statewide health plan and principles around payment or budgeting, and so might be helpful. So narrowing to hospital budgets, which is a piece of the rest. Before that, or while that's happening, you're thinking about there has to be a plan in place so that what happens here and what happens there are coordinated.
Correct. So
Yeah.
there are a number of principles in section 9371 of our statute to which we're required to regulate. There's a series of 9371 if you look at them. And there's a series of guiding principles and policies, our rules, our regulation, and our guidance that we put out. So they are, I forget how many principles of healthcare reform there are that we regulate to.
Some of those are Act 48, which are somewhat directed toward single payer. And I don't know how they sugar off with where we are right now.
Yeah, I mean,
Good.
I don't have in my head all of them right now.
Me either, but
Many of them are
I
still
know.
relevant though.
Yeah, I mean, one of them is this, it should be a system the state can afford. I mean,
Yeah.
that's a principle that I think is fair and balanced. We also want its sustainability, it's supporting
Yeah.
primary care and mental health care. Those principles, I think, are all very important and stand the test of time. I'm sorry, Senator Lyons, your second question.
Well, I always ask the question about a 2-year hospital budget, but it seems that it should be maybe a 1-month hospital budget.
We tried the 2-year
We did.
hospital budget.
We did the hospital association, I wasn't here, but I think they had requested a 2-year hospital budget guidance, and we did that. However, we set it at 8.6%, so 2-year increase of 8.6, which is the high end of the state goal. But many hospitals weren't able to live in that in the first year, and then the request came back and said, let's change the guidance to higher because we weren't able to do it.
Yeah, difficult.
So we have done
We
it.
tried, it didn't work.
It didn't. I think it
Yeah.
set an expectation, but the expectation was there in statute in the all-pair model anyway. So
And then what I mentioned, population health outcomes and how you measure those within the framework of hospital budgeting, and quality metrics, measurements, how that is utilized. Does the board do any of that? Yes.
So population health is not, I can think of a direct factor in hospital budgets. And I don't know if it'd necessarily be a fair factor
Mhm.
because population health is comprised of so many things beyond hospitals. So what do? If population health is going down, we give hospitals less money, we give them more money. So a lot of these things, you guys say, well, what do we do when we get the information? If we see really poor population health, do we give less or more? I don't know the answer to that. I think on some level, you might say, well, we're giving a lot to the hospitals and the population is health is going down. Maybe we need to do it differently. Or are we, it's really more, so look, a hospital's only somewhat responsible for population health. You also have, the mental health providers and everyone else. So if that's not part of your analysis, food, right?
All your prevention
all
efforts
these
out in the
things.
community. Yeah.
So is it fair to really hold a hospital accountable for population health entirely? I don't know that it is. It's such a confounding thing to measure. Quality there, I would like to add a quality program that's more robust than what we have. It's not robust. It's an area where we could do better, and we have seen some signs that quality can improve in the state. So if you think about quality, there's many different ways to measure hospital quality. There's many different organizations that do this. So which one's the right one? Everyone, somebody will say is wrong if they don't look good at it. They don't like that, which is understandable. And some of them probably do have some weaknesses to them. But what we're currently doing is we look at some of the national reports and we look at the hospital's own data. So hospital acquired conditions, pressure ulcers, things like that. We're looking temporally, are they going up? Are you getting fined by Medicare for quality? And some of our hospitals, unfortunately, in recent years have been fined for quality by Medicare. Medicare has a program where they'll impose fines if your quality slips below the lowest 25th percentile in the country. So we want to make sure quality is high. But again, then what do? Quality goes down, do you give more money or less?
I can just add one of the challenges with quality data is with small hospitals with small numbers, often the data is obscured, right? So if you look on Hospital Care Compare on the Medicare site, and you look at some of our small hospitals, you see a lot of NA, and some of the really key metrics. And so we have a challenge of small numbers.
That was the value of the all payer value-based payment model for primary cares. You can look at a larger group.
Yes, wouldn't be particularized to a hospital.
Yeah.
And we saw mixed results.
Okay. Other question. Go ahead.
Yeah,
Senator.
I wanted to get your thoughts on S10 up there on the board for the certificate of need. So the threshold on that it's 3,000. Or sorry, 3
Oh,
million.
that's a CON bill? right.
Yes, that's yours.
Right.
Yeah.
Oh, we're gonna have them in to testify, but you want to ask them now?
Yeah, I just wanted to get their thoughts on that. Should the threshold you have is 3 million, correct?
I think it is.
Yeah, should the threshold be higher? Should it be lower? Should it be 50 then, or 50 million? Or should it be eliminated entirely? Because I've heard arguments for all three. So,
One caveat that Member Holmes I should have put in when we started, I apologize, is we are 2 of 5 board members, so our views are really our own.
yeah, that's what I'm asking for.
Yeah, none of us can really speak for the collective of us, but we'll give you our own opinions. I would need more time to dig into the bill, and there's a lot of nuance there. Directionally, I do think those thresholds should be increased rather significantly. I think if you look at how they've been implemented, the cost to hospitals to get some basic things that they need, we shouldn't be spending 2 or 3 months. They shouldn't be spending legal fees. It's bureaucracy. They shouldn't be doing it. And then second, for the non-hospitals, it is a barrier to market entry. And if we look back, it's important to look back at what we did and think about how it worked. The Green Mountain Surgery Center CON process was not helpful. That organization went through a pitched battle about their CON.
Oh, and it was in here. First we had to write what they were going through. And then you had to put it in place.
Yeah, and as I understand it, and Member Holmes was here, it narrowly got through. In hindsight,
It was hard.
it was a tough thing, but it's really been a very beneficial thing to the state to have this organization there to do a large volume of needed screenings, colonoscopies at a very affordable price and high quality. It has not hurt the hospital finances. If anything, it's been a boon to the state. But that barrier to entry, I think, was in hindsight not productive, and a lot of legal fees were spent on that. And there was a delay. So that's my view. I think they should be increased.
I agree.
What about eliminated?
I would eliminate them, and I'll tell you why. There's a difference between nonprofit and for-profit. And in some ways, it's really great to have nonprofits. In some ways, it's different. A nonprofit, if they take a bet on something, if they build something with an expectation and they're wrong, and they lose money, what happens? They come to us and say, we need more commercial rate because we have losses and we can't afford the care. So the collective, there's a too big to fail issue, and we all pay for it, right? Now, if it works, it's great, and the business grows and it's really good, but that doesn't always happen. The nonprofits, sorry, for the for-profit side, they lose their shirts and they're out of their own money. They can't come to us and say, hey, we need more money. So it's a little bit of, it's more complex than that, but there's a little bit of difference. Some of the conditions the board imposes through CON are very, very, very valuable to the state. So I wouldn't eliminate it for that reason. If you look at the Green Mountain Surgery conditions of their CON, they had to take Medicaid patients. They had to keep their prices below the lowest cost hospital in the state. If there's no CON, they could try and charge a lot more and not take Medicaid. They do take Medicaid and they have their prices that are low. I think they would probably do that on their own, but the board conditions require it. The UVM Outpatient Surgical Center, when it was proposed, I don't have the exact numbers, but the prices that were included in the proposal were extremely high. The board narrowly approved that CON, and one of the conditions was that the prices had to be the average of what outpatient surgery centers are in the country, 170% of Medicare. I believe the prices that were proposed were a multiple of that. So we were able to reduce price, which we felt was appropriate, and hopefully it comes to pass, and I hope it gets built.
Other questions? In the beginning, this is great. And thank you for your work, and thank you for being available to us to educate us. It's very good.
Thank you for having us and taking the time to.
We all have a lot of hard work to do, so.
Well, you will be back.
We do.
We have the CON bill, we're gonna have the EMR bill, we're gonna have all the
Another
different-
CON bill.
and another CON bill that'll raise the threshold of whether.
Everything's done.
It's discussion.